CEO and founder of Life365, and welcome to Season 4 of The New Normal. On today's episode, we will discuss the innovations and technology helping transition care from traditional points of care like the doctor's office to the home and the daily lives of patients. Before I introduce our panelists, I want to take a minute to thank you for joining us today, as well as thank our panelists for sharing their time with us this afternoon. As for the structure of the webinar, attendees will be on mute, and we have reserved time at the end for questions. Please place your questions with the question box or the chat box. You can review a recording of today's webinar on www.newnormal.buzz. Now to introduce our distinguished panelists. Don Jones is a globally recognized leader in digital medicine. Over the last 40 years, he has worked with more than 65 companies in pharmaceutical, medical device, wearable, smart apparel, material science, and healthcare. He is an operating partner with Takeda Digital Ventures and has advised the boards and executive suites of Dexcom, ResMed, Cepheid, sorry, I'll get it right, Cepheid, Sanofi, Teva, AstraZeneca, Genentech, Otsuka, Nova Nordisk, and Verily Santa Fe joint venture on Duo. He is a senior advisor with both McKinsey & Company and the GLG Institute. Jones serves as the Chief Digital Officer of the Scripps Research Translational Institute and co-founded Scripps Digital Medicine with the renowned Eric Topol. Don founded Impact, the virtual first healthcare provider collaboration. Don also founded the Wireless Life Science Alliance and the $10 million Qualcomm Tricorder X Prize. Earlier in his career, Don was COO of what is now Global Medical Response, which grew from 4.5 million into the largest emergency services provider in the world. Welcome, Don.
Thanks. Well, happy to be here. Look forward to working with Joe here today.
Yeah. And Joe, Dr. Kvedar is a professor of dermatology at Harvard Medical School, immediate past chair of the board of American Telemedicine ATA, and the editor-in-chief of MPJ Digital Medicine. He is co-chair of the American Medical Association's AMA Digital Medicine Payment Advisory Group, DMPAG, which works to ensure widespread coverage of telehealth and remote patient monitoring, and successfully established several new provider codes for telehealth reimbursement through the CPT process. He is the author of 2 books on digital health, The Internet of Healthy Things, and The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan. Welcome, Dr. Joe.
Great to be with both of you today.
All right, so Don and Dr. Kvedar, I'm going to go and ask you, just tell me a little bit about what you're working on today. We can start as a reference point, then we'll start getting into the history of digital health. Dr. Kvedar?
Well, so call me Joe, Kent. It's much, okay. Unless you want to come to the office as a patient. So I split my time now. It's an interesting portfolio, and you mentioned a lot of it. I do see patients still 2 days a week, which includes a half day of telemedicine for my dermatology practice at the Mass General in Boston. The editor-in-chief job at Nature Digital Medicine is about a day a week, and it's a growing journal, extremely exciting journal, which was founded by Don's colleague, Eric Topol, and others. I took over in 2020. Chairing the AMA DMPAG is another role that I really enjoy. That's helping move the whole reimbursement frontier forward. Spent some time still with ATA, even though I rotated off as the chair. I'm still heavily involved with that organization, and I advise somewhere between any given day 6 or 10 companies and sit on a couple of boards. So it's enough to keep me busy. It's a nice portfolio. And it's great because I work with people I want to work with, and I take projects that I want to take.
That's awesome. That's awesome. Don, what about yourself? What are you up to nowadays?
Well, I sit on 8 boards and have a similar number of advisory clients, kind of a mix of VC and PE-backed companies, and also some Fortune 500 companies mixed in the mix there. Where I spend a fair chunk of time is with Takeda, the big Japanese pharmaceutical firm. We have a they actually have two venture funds. One does biotech only, and one does digital health. But the digital health fund is actually very narrow in its focus. It does virtual first healthcare delivery and technology enabling platforms for virtual health, and that's it. So it's a very narrow thesis that we invest in. We've got about 8 companies in the portfolio today, and the fund is about 3.5 years old. So I spent a lot of time there, funneling new companies into our investors that are in that group, and working with the companies that are in that portfolio. We just had a nice kind of win there. Oshi, which is a virtual GI practice, just published. I think Joe nodding his head. We just published an article with United Healthcare showing over $10,000 in savings on the Oshi GI model per patient in less than 6 months.
Wow.
It's a huge move, although I actually have heard from some physicians who don't believe it. So we'll have to we may have to do the second and the third study before people start actually buying in. But it's a very different care pathway for the patients, and obviously we think it's got really strong results. So that's one area where I spend a lot of time, is in that virtual first care space. And then another area I spend time in that I really enjoy is with a company out of Sri Lanka, which is in the material science area. They're really one of the world's largest apparel manufacturers, but they happen to be in what I refer to as the tight-fitting apparel market. So they do fitness clothing, athletic clothing, and lingerie. And I get to wave the flag to say I worked for 7 years for the world's largest lingerie manufacturer, but it's not Victoria's Secret. But they do manufacture for Victoria's Secret. But where I work on is in smart apparel and clothing with, and not just clothing, it's headbands. We're doing almost all the headband work for the VR industry, and a lot of work in the CPAP industry. And these are all opportunities where clothing may just not be clothing per se, but it may be bands, and the bands may have electronics in them. It may have wiring in them. It may have sensors. It may have switches, etc. in them. And if somebody wants to see an example of some fun stuff we've done, you can look up Wearable Experiments. Wearable Experiments makes yoga clothing, much like Lululemon in the look and feel, but it's got haptic sensors in it. And based on yoga courses that are on your phone, you actually feel the instructor's hands on your body, theoretically, through the haptic sensors that are in the yoga clothing. So that's one example you can actually go experience and purchase today.
Wow.
So that's just one example of what we do. That's not necessarily a healthcare product. In the healthcare world, we just launched with Therabody some extremity effectively braces or the slide-on extremity devices that can add heat and pneumatics to impact blood flow. And so you can, these are now commercially available through Therabody, a well-known brand, and these have a little rechargeable capsule that slides into place on the device, and you hit the on button, and now instead of just a passive brace or a passive compression stocking, if it's on the lower extremity or on the up, and these also work on the upper arm, you add the heat and you add active compression, so you actually get the rhythmic kind of massaging impact that you would expect in active compression. So those are just a couple of good examples. Fun company to work with. All kinds of crazy stuff we do around lighting and sensors and all kinds of technology for all kinds of different industries, including many of the big tech companies.
Awesome. That sounds great. One of the things that, I want to go back on a little bit. I've probably known both of you probably about maybe 12 or 15 years, right? Through, the previous companies and stuff. 12 to 15 years ago, it was almost like a land rush, right? A land grab in digital health, that every big company was going to go after digital health and bring it out. And it stalled, right? For obvious reasons from that as well. Or do you think it's stalled? Do you think it's a natural progression, from where we were to today? I mean, I'll mention the obvious one. We didn't have reimbursement back then, right? It caused part of the stall. But where do you see us at today, Joe? Right, from that versus where we were 12 to 15 years ago? Are consumers getting more, used to this type of technology in a way and not more knowledgeable about this type of technology, or are we still in the education phase?
Well, there's been progress, but you can't deny that. It's for someone like me, it's never fast enough or enough. But because I think we're still underperforming in how we offer care in a virtual space, whether it be omni-channel or whatever you want to call it. You know, with that said, if we think 12 or 15 years ago, and I don't remember the name of the company, Kent, that had the little wireless hub that we used.
iMetricus.
Yes, yeah. So that was an example which was innovative at the time. We compared it to plug-in modems but the concept of uploading a blood sugar or blood glucose was the same, and now everyone's mobile phone is the hub. So we're getting there. I like to say that we're in a 50-year arc. I don't know where we are in that 50-year arc. I would say maybe 20, 30 years in, where we're moving away from the center of the care process being the hospital and the doctor's office to being at the edge of the network, to use a sort of networking term. When I grew up in central Vermont, I was born in 1957. Everything was at the local hospital, doctor's office, everything, because that was the information system. Now I can get my a therapy session with someone who's in a different state. I can get my x-ray done down the road, have it read in New Zealand. So we're getting there. It is getting decentralized, and we're making progress. But like I said, I still think we've got a long ways to go.
Don, from your perspective?
Well, I think the only thing that's slowed down in reality is the number of billions of dollars being invested. So we hit a peak in 2021, fell off a little bit in 2022, probably fall off a little bit more in 2023. But if we look back over the history, we're still at very, very big highs in terms of billions of dollars being invested in digital health. And I think there's a likelihood that we'll see another high, that this will be a wave, is going secular, and we'll see another wave here in probably 4 or 5 years, from my best guess. But I think I agree with Joe's comments. We've got, we're in a society now that the consumer, the way the consumer accesses products and services has changed dramatically, and lots of companies have played a role in that. You can use Uber as an example, Airbnb, Amazon, etc. And frankly, like it or not, the traditional healthcare bricks and mortar systems are being impacted by consumer expectation that says, "Why are you so far behind?"
Mm-hmm.
And frankly, the dirty little secret about a lot of digital health companies is their success. The ones that are finding their successful business model, they're often doing it on convenience. They will eventually, and in my mind, and I'm sure Joe probably agrees, prove things out on clinical outcomes and on costs. Those things take a long time to measure and be validated, but convenience is something you can actually win on overnight. And frankly, the traditional bricks and mortar delivery system make it pretty easy to compete on convenience. So it's an easy way to kind of get the foot in the door. I just had an opportunity to hear the head of mergers and acquisitions for Amazon speak at a conference in Scottsdale, in your backyard, Kent. And he was asked by the head of healthcare investment banking for Morgan Stanley what his thoughts about healthcare are, because he's not a healthcare guy. He's just a generalist M&A guy. And he's now done multiple healthcare acquisitions, PillPack, One Medical, and a couple of other smaller ones. And he said, we've studied it a long, long time through the eyes of Amazon, et cetera. He said, we're probably going to make some mistakes. We're probably going to learn some things we didn't know. But at the end of the day, our view of healthcare is it looks and feels like it's run by the government. And the closest analogy we've come up with is the DMV.
Right.
So
That's good.
I don't know whether that's a damning statement or just an accurate one, but it basically says if you can figure out how to deliver things more conveniently, faster, better, cheaper, you've got a shot. And I think that's what most of the digital companies are trying to do, is they're saying, how can I be better, faster, cheaper? I think the clinical outcome piece is usually 18 months to 36 months down the road to be able to prove that. And so the better, faster, cheaper element is usually what's winning the day here early on, and that's fine. That's how a lot of things get started. And so I think I think that's what we're seeing today. Certainly a lot more shift in the early days when I first got to know you, Kent. We were looking at a lot of devices, and one of the things Qualcomm taught me working there for 12 years was that devices come and go. Today's greatest device is probably tomorrow's little antiquity, and there'll always be something better coming out by somebody. And so just like you expect on your cell phone, even companies that think of themselves as medical device companies have started to take a more consumer electronics approach. I remember speaking with the former CEO of Dexcom at one point, and he said, listen, I'm at the point now where I have one device in the market, one on the bench and final development, and one in R&D. And every 2 years, I'm rolling out a new model. He says, that's the consumer electronics business. That's no longer the device business that historically designed for 12, 15 years product lifetime. So I think what we're seeing now is services are popping up, and in a big way. I mean, obviously the pandemic played into this, but there were already a lot of services starting to pop up, and there's now more in the virtual first space, which I loosely define as taking everything you possibly can to the patient where you find them until you can't. That means organizing everything else they need, shipping them their durable medical equipment and or prescriptions. Just really not just telehealth is a component of it, but not all of the offering. The Impact Group just put a directory together, and they're now tracking over 200 companies. 4 years ago, I don't think they would have come up with a handful. So we're starting to see the services move.
Joe, do you want to step in? Seems like you want to say something, or as a
follow-up? No, I'm learning along with our audience here. I agree. It just to reiterate a bit what I said. It's a journey. I wish. So I'll say this: traditional healthcare is holding us back. Traditional healthcare delivery is holding us back. Because we still think we own the relationship with what we call the patient. Don's referred to consumers. And you're absolutely right. I said this the other day at the ATA meeting, that all of those firms that you might criticize for marketing on TikTok or doing some questionable things, they wouldn't be successful if we as traditional providers were filling those needs. And the reason that they're all growing like crazy is that we're not. We make it hard for people to get a service. It's tragic, but we do that. So hopefully we can, and I love virtual first because it really gooses us to get our primary care innovation going. Primary care is the lifeblood of our organization. If we get that cut off because Amazon came into town and took it away from us, we will be in serious trouble. So it's motivating. In a way that just simply saying telehealth reimbursed is not motivating. That's the people say, well, I'll bring you in the office. Thank you very much. I'd rather get the ancillary services, like when you order a lab or you order a x-ray. But if they say, well, Amazon's offering a service very competitive, cheaper to the health plan, and it's probably going to take primary care away from you, then people sit up and take notice. So I'm happy to see that happening. And it's a little bit disjointed right now, but that will all sort out.
Yeah, we've certainly, in our company have adopted the whole term of virtual first, omni-channel virtual first, from that standpoint, because it's not remote patient monitoring is just one brick, an aspect of that. Right. There's a lot of opportunity that we have in doing some pre-processing upfront for major enterprise health systems to try to get some of the data they need to run through their analytic and AI systems, that they just don't have the time to do it, right? To be connected on the outside too. There's a major advantage. The one thing I was going to ask you, Joe, was, the pandemic itself has really kind of accelerated things. You know, people say this all the time, accelerate things that are already moving, how we, you know, have food delivered to our house, how we have, you know, meals delivered to our house. You know, it's really kind of telehealth, right? Was a good example of that as well. You know, it really has transitioned to be more of a consumer and provider directed marketplace from that standpoint. But I see this from, I'd like to hear from both of you guys. You know, I think in the next 10 years, we're going to see major consolidations of health systems where there just are 8, 10, 12, 15 very large health systems, CommonSpirit, you know, maybe Johns Hopkins, maybe HCA, you know, some of those that are out there that are regionally divided, and each one's going to be a payer, each one's going to be a GPO, each one's going to be, you know, a telehealth, and each one has to have community-based care, right, to connect into them as well, and telehealth. What's your thoughts on consolidation in the marketplace and the need for those major systems to now spread out and do more connected community-based care to get a hold of their patient base, but also to control their cost as well?
Well, so I'll take a first stab at it. I think we might be pushing the limits with a caveat that, and I often use this caveat when I'm describing the healthcare delivery system, the delivery system part, which is we're hamstrung once again, because so much of what we do, and we insist that people come to a physical location for it. So when you do that, I think you can only get so big before you stop bringing out the value of consolidation. Case in point, and I don't know that I want to make sure that people listening know this. I don't really know whether this is going to succeed or not, but Advocate Aurora just merged with Atrium. That's a lot of footprint, and I just don't know how much they can squeeze out of that, you know, executive layer to make that more powerful. You know, you throw in again a company like Amazon that doesn't have any of those constraints of having large buildings that they have to pay the rent on. That may be, again, that may be the disruptor that changes it. But so I think there's limits to what we can do at the large system level. And the organization that I work for, now called Mass General Brigham, it's hard to imagine that not being it's a New England hub of excellence. Maybe some people feel like more than that, but certainly it's a New England hub of excellence. And it's hard for me to imagine us being sort of part of something that's, say, Atlantic wide, or right. I just think at some point it falls apart. But maybe I'm wrong, and I'd love to get Don's opinion.
Yeah, John, I want to ask you really quickly. I want you to comment on this, but also try to weave in the whole Glenn Tallman and Transcarent and, you know, model as well into it and where it's moving to.
Sure. You know, we're always going to need hospitals. So the end game here is a hybrid model. And you know, I'll pick on Joe's field because he can comment back on it. But if you know, telehealth applied to dermatology might frequently lead to the notion that I need you to come in because I've got a biopsy.
Exactly.
Because I can't do that. I haven't figured out how to do a remote biopsy yet.
Right.
Maybe we'll have technology where you can self biopsy.
Yeah.
Especially some of the more common skin lesions that come.
Yeah.
But we don't have it right now, and so we're going to need a model where a telehealth dermatologist can say, "Listen, I need you to go to XYZ destination, just like I might need you to go to LabCorp or Quest in order to have a biopsy done." So now maybe the local office, the bricks and mortar, isn't so much the derm office as it's the biopsy office. And every single specialty in medicine kind of has a similar set of additional data gathering functions they need that require some hands-on elements. And we've got to figure out how to deliver them. And many of the companies I work with are doing that. In the GI practice, Oshi, it's a full service GI practice, multi-specialty. It includes clinical psychology and dietetics and coaches and internal medicine. We actually engineered out a lot of the GI doctors because we don't need as many GI doctors in this multi-specialty care delivery model, but we still need them for scopes, for endoscopes and colonoscopies. So in the traditional model, you would make a referral to a GI doctor who did scopes, and you basically expect the patient to go live over there for their GI needs. Instead, what OSHI does is they, through service level agreements, makes arrangements to buy the scope, much like you would buy a CT scan or an MRI. Patient comes back to OSHI, the results come back to OSHI, and OSHI continues to manage the patients. It actually works out fine for the GI docs because they actually do fine financially doing scopes, and they actually spend a lot of time doing scopes. So it's not necessarily a bad arrangement. And frankly, a lot of the patients had trouble getting the ancillary services of the mental health services and the nutrition services all in one place anyway. So it's a different practice road, but it points out this hybrid model. Regarding transparent, really folks sometimes need to step back and think, who's paying for services? Well, a third of the services are paid by government through Medicaid and Medicare. A third are commercial, and a third are employer. So we really have three big markets, and Transcarent's going after the employer market. And what's interesting about the employer market is it's really becoming fairly rapidly the first market that's actually saying, this is what I want to buy, not what you're selling. In other words, I don't really like what you're selling. I want to buy something different. And so through a lot of point solutions offered by different companies, in some cases, some of those companies are quite large companies, the employer is saying, I'd like to buy X. And the marketplace is coming back and say, okay, we can create that for you. And whether that's, on-site clinics, on-site mental health, virtual on-site clinics, virtual on-site mental health as a starting point. In some of the on-site clinics I'm aware of, they now bring in the specialists that are common, that come in a lot. So endocrinology, dermatology, even cardiology are sometimes coming to the on-site clinic. So, and why is that happening? Well, the buyer, the employer is saying, I don't want my employee away from their desk. I want to preserve productivity. I want them in and out of the medical system as fast as possible because it's costing me money. So I want to buy a different product. We had an example a number of years ago at Qualcomm where we went out for bid for urgent care in 3 communities in California. And one of the requirements in the package for a very large, at that time, Qualcomm was the largest private employer in San Diego. One of the requirements was front of the line privileges at urgent care. I can tell you 2 of the healthcare system urgent care said, we can't do that. And the response from Qualcomm is, that's fine. We understand that that's not what you're offering to sell, but it's what we want to buy. So we'll just find it somewhere else. And they did. So I think what Transcarent is tapping into is that notion that employers are slowly becoming the activists in terms of, this is what we'd like to buy. They're becoming smarter buyers of healthcare. And it kind of sounds crazy, but I would argue that health plans have not been smart buyers of healthcare. They've been smart payers of healthcare, but not smart buyers. They haven't dictated the terms. The concept of service level agreements in place is almost non-existent. It took Medicare to come along and come up with a warranty that says if you bounce back in the hospital, we're not paying for it. There's actually a warranty on your work. A lot of the other health plans look and go, well, that's a pretty good idea. Maybe we should have that too. But if you're actually an active buyer of a product or service, you have some minimum level of expectations. And we're just seeing that pop up from employers beginning to say, we'd actually like to buy services with some expectations on what how they're delivered, what the impact on our employees are from a presenteeism, productivity perspective. How do we meet the employees' demands so they're more instantaneous, more Amazon-like, if you will, Uber-like, and how do we do it in a way that actually ultimately delivers some value, both clinically but also economically.
Absolutely. We've got some questions that are coming in out here. I'm going to throw a couple of them out in between, but I want to go. The one thing I want you to think about is, what are you seeing out there that's emerging that you really like as far as, technology solutions, best practices. It doesn't have to be a gadget, right, from that. But coming from Napoleon, he's asking, please speak to medication telemanagement as key to home care success. also to challenges with the implementation of medication telemanagement and the relationship of remote patient monitoring to medication telemanagement, RPM examples, pacemakers, and glucose management from that perspective. He also said, please project the effect of the retail companies like CVS, Amazon, Weight Watchers, and much others entering home care as well. So let's just throw it out to you, Dr. Kvedar, to Joe, about the telemanagement or the telemedicine.
That all those questions add up to a whole nother podcast, but I'll try.
They do. Right.
I think so. If I'm understanding the term medication telemanagement, I think I'd reword that as adherence, technologies that promote adherence. And we've studied those. We've implemented them over the years. We've paid a lot of attention. I have personally to that market. And it seems to, I don't know of a good example of someone who's succeeding. Perhaps Don does. And here's the reason I think why not is because nobody really feels like they should pay for adherence. Like as a doctor, I write a prescription to you, the patient. I expect you to do what I ask because you came to me. I'm an expert. This is my advice. Straightforward, right? Well, of course not. You go home, you forget, you don't. So there's a gadget, whether it's an app on your phone or a physical gadget that can remind you to take your medicine, right? So, okay, that's great. Well, who's going to pay for that? How about you, the consumer? You're the one who's on the hook for the better health, but no, not really. No, nobody does that. So, well, how about if we try your health plan? They look at it and say, it's not my job to remind you to take your pill. So that to me is the issue with adherence. And I haven't seen anyone solve it. There's been several people who've made a good run at it, and I can think of both an app and a couple of gadgets but I don't think anyone's scaled it yet. So that's my thought around that.
Yeah, I think generally agree with Joe here, but I think there are some examples where adherence tends to work is where there's good feedback. And I'll give you the obvious example everybody can do. Everybody is adherent around pain.
Well, of course. Yeah.
Because there's a nice feedback loop.
Or orthopedic injuries. Yeah. It's the things like high blood pressure and high glucose that are harder.
Yeah. So we have had it, interesting enough, we've had an interesting example in the glucose level, though. A really interesting story. Just this year, probably about six weeks ago, the FDA approved a product by an entity called Tide Pool, which is a nonprofit. It was basically assembled by a bunch of parents of type 1 patients in order to get effectively a fully interoperable artificial pancreas function that would manage the dosing, the adherence, but more importantly, even the dosing. I guess the two go hand in hand, really, in all practical purposes of the drugs necessary for a type 1 patient that was on a pump that also had a continuous glucose monitor as part of their system, and may even have connected insulin, where the insulin's actually, how much insulin's being loaded on board and becomes part of the software program management, which is really now a disease management software implementation. All of that was put together by parents. It was a crowdsourced medical device. Now think about it. How we have a crowdsourced medical device that is essentially managing drugs that fall in the category of too much or too little will kill you.
Yeah.
The crowdsourced solution came together, got tested by some 5,000 people who put either their kids or themselves on the platform, did the clinical trials necessary, and got it through the FDA.
Awesome.
Now that was
a remarkable story, yeah.
But it's a remarkable story. And it's a remarkable story about medication management, adherence, titration. And actually, frankly, it's a remarkable story about making people's lives easier and better. Right. And that's really the problem that was being solved for. And it was done by a group that actually titled their whole effort of "We're Not Waiting," which was basically a slap across the device industry saying, we're not waiting for you to come out with it because you apparently just keep coming up with excuses. Yeah, so right. In terms of, and maybe some legitimate excuses, there's a very complex set of answers behind that. But at the end of the day, here's a group of moms and dads that banded together and got an FDA approval on a crowdsourced medical device on one of the most complicated systems medical systems you could imagine for the concept of adherence and dosing and titration.
That's an
course,
awesome story.
the end result of that, or the asymptote of that, is that you don't have to think about it. You just plug a couple things in and it works. And that's automated adherence, I guess. So that's a wonderful vision. And I think maybe unique to diabetes, but a great story.
Yeah,
Hey,
and so
Don,
to
go
that
ahead,
end,
Don.
one of my favorites, just to answer your question about technology, is a company called BioLink in San Diego that is going after the continuous glucose monitoring space, but that's really not their core competency. Their core competency is measuring any analyte on a continuous basis. So you have to start thinking about how does medicine respond and incorporate into adherence, into titration, the notion that your labs are available with a new update every few minutes.
Right. I love that. Yeah.
We know that answer pretty well now in glucose.
Yeah.
But as I'm sure Dr. Kvedar could offer up some theories, what happens when we have it in potassium for patients, for kidney patients and any other analyte, and how does that start playing in when we number one now don't have to go to a LabCorp Quest site, and number two, we're actually not getting an episodic measurement, we're getting a continuous measurement, and now trends are what's important, not absolute measurements.
But to that point, Joe doesn't need any more data on an ongoing basis, right? But the AI and machine learning systems do, right? From that to be able to, and so Joe, are you potentially trusting of getting some input back from the AI and machine learning systems that are showing you maybe some trends or maybe some suggestions from all that data that's coming in?
Yeah, so I'd say I will answer that, but I wouldn't throw away the Joe doesn't need any more data part, because that's to me that's not enough humility on the provider side to say that. How do doctors know? They're used to working on, as Don would say, one potassium every 3 months. I think we would be arrogant to say we only need that one. We don't know. It's sort of like back in the day when we started measuring these things, we had to have 300 normal people to find out what the normal range was. We have to have studies where we find out what the normal range of these things are. So I just wanted to point that out. In terms of the AI, absolutely. The best quote I've heard lately about that came from Sundar Pichai when he was interviewed by a reporter at the Wall Street Journal. He said it's giving you a really good first draft. Okay. And what you can't, no first draft is the final draft. But that's how I love thinking about it. It's going to give me, and if it does a good job, there's of course many things that computers can do better than my brain. And of course, there's things that I can do better than a computer. So we work collaboratively. But again, I'll take the advice. Hopefully I won't go to sleep and just implement that advice without thinking about it. That's the danger that we all worry about. But it's probably going to give me some very salient advice about that patient that I either haven't thought of or that I need to take into account. And the better it gets, of course, the closer it gets to being exactly what I need to do.
I'm going to say you're a little bit of a unique doctor than most because you're around, digital health and data as well. But I still get the statistics from people that, Mayo Clinic says that, their physicians have to document 80 minutes per evening into the electronic health record just to get their job done. A lot of physicians are still worried about remote data coming in, patient-generated health data coming in, and there is some type of trigger that's triggered from it, and they don't see the alert or the trigger in a 24-hour period from that. That's the only reason why I was saying that doctors don't need any more data, but you've got to have these front-end systems that are kind of helping with the automation and pinpointing the situational awareness of like, who is the person you need to go look at, right, from that.
Yeah,
if that was helpful.
I would just say that, I would just say that in every Fortune 50, perhaps, maybe more, executive has a real-time update dashboard on sales from around the world. We can do this. We just haven't asked. We haven't asked our tech companies supporting healthcare to do it. We can do it. We can get all that normal data streaming in to be something that's not just data but insight. We have the means to do it.
It's a really interesting challenge and opportunity, and that's really what we're seeing. A lot of third parties coming up to actually do that effectively, the monitoring and, signal the interventions that may be necessary. It's really not, it certainly isn't, from any consumer's perspective, a good response if a healthcare organization says we don't want the data because we don't want to interact with it, and so the result is we're going to wait till the patient crashes and ends up in our ER. That seems like a really bad.
I agree. It's not a good PR move.
Not a big PR move, and certainly not a good business model. What is interesting, I think, from my perspective, is that just like the Amazons and Walmarts and CVSs, as they get large footprints of primary care patients, they're going to have large footprints of referrals to be made. And the question is where are those referrals going to go? And
we'd like them to come to us.
And yeah, I bet you would, Joe.
Well, that's a question from the audience. Is like, is Amazon going to start either acquiring health systems or partnering heavy with health systems for those referrals to go into those health systems?
Well, I'll pass along what I heard from the head of M&A at Amazon just last weekend, and the answer was we're certainly not buying any hospitals. Okay. But we might be putting some hospitals under service level agreements if they want our referrals. And right. And they're going to be asking the question, what's a service level agreement? The IT folks know what it is because they've been asking for them, but they haven't. Nobody's asked for them on their healthcare service provision before. So I would expect that to be part of the landscape here over the next 5 years. Is you're going to see these big organizations that are generating lots of referrals start to make demands on those. And why are they going to do that? They're going to do it for a couple of reasons. One is they want to manage the customer relationship. They want the customer to have a good relationship downstream from their referral, and they're going to be concerned about how that relationship. So they're going to lean into that and put some weight behind it.
Totally agree. It's really your Oshi model, I think, is that's one example. Let's say.
Yeah, exactly.
Yeah, back to the virtual first side of it. I tie mobile first to it as well. Right from that, my term, maybe the industry's term, but I'm starting to see MedArrive and Dispatch Health and, and DocGo and Medically Home, and you saw the relationship with Medically Home and Best Buy emerge this week as well. From that standpoint, I think that mobile first and virtual first work hand in hand, right? And Don, you used to come from GMR, right, from that. And so you've got to be maybe a proponent of, instead of picking up somebody and taking them to the hospital, the ER, that you want early insights using the data and having just-in-time care and trying to do predictive care ahead of time to intervene with maybe mobile first if you need to. Does that resonate at all with you in that?
Well, I have a pretty unique background because I was in a business that we delivered care to a person every 4 seconds in America.
Yeah.
At a location that we only found out about 10 minutes before we were supposed to deliver the care. And we had to go to them, not make them come to us. That's what an emergency medical services system looks like, and at scale. And the way I ended up becoming the chief operating officer, what we grew to become the largest in the country, is because I figured out predictive modeling and when and where 911 calls would occur. Number one, which if you think about the last time you waited for a long time in a doctor's waiting room, that's an example of not figuring out predictive modeling of what the patient queuing should look like into the waiting room. But we figured it out for 911 calls, and then we came up with a dynamic positioning of all of our available resources. So we ended up with a situation where we were able to take 30% of our assets off the road and improve response times by looking at that predictive modeling. So I grew up with that. That actually happened when I was 27 years old, and I'm a lot older now. So I totally believe that you can apply predictive analytics in very productive ways in healthcare, and you can actually improve the quality of what you're delivering, the product you're delivering. There's if you think about it and just step back, it actually should make you a little frustrated, if not ultimately mad, and that is, why is there a 4 or 6 hour wait in an emergency room? Well, it's because there's bad planning. Any other business, if you thought if McDonald's said we've got a store and it takes 4 hours to get your Big Mac in line, they'd fix it.
Right.
They'd build more stores. They'd do something. But we don't, for any number of arguably complex reasons, we don't take that attitude that says we've got customers lined up around the block, maybe even double density around the block, and we're not fixing how the supply and demand aren't coming together. So a lot of what's happening in the digital health space is trying to make sense of supply and demand.
Right. No, I get it. There's a key here. If you want to get ahead of the line in the emergency room, either say you're having a heart attack or you fell off the roof from that and have a head injury, you'll get to the front of the line, right? So
you can game the system. There's smart people that know how to game the system.
I know, I get it. we're going to tie up here in just a little bit, but Joe, you know, how did the pandemic affect how people are thinking about digital health? Employees that are going home, right? Are they healthier? Are they more informed, right? Are they, I mean, I know we're having a lot of behavioral issues, right, that came from the pandemic. Do you think, how did that affect from the digital health perspective, right? Not just mental health, but, you know, physiologically, people now working from home, they're not getting up as much, right, to go to lunch with colleagues and, you know, right, from that perspective, what kind of impact has that had?
Yeah, I was I'm taking in a different direction. So excuse me, I haven't seen data on how if more people are more sedentary or not. I know there's at least a chunk of folks who are more active because they don't have commuting time and they've switched that out for exercise time. So I think it can go in either direction. I don't have any stats at my fingertips on that. I will say that the experiment, and it really was that from March to June of 2020 that made everything telehealth all day, all the time, was good and bad. The good was that people now, almost every person I meet knows what that means. If I say, if you want a telehealth follow-up, I don't need to explain that to a patient. That's a good thing because it helps us sort of create a new floor for innovation in healthcare delivery. The bad part is that people got confused and they thought, well, I guess I can do everything by telehealth. And of course, that's not true. As Don was saying earlier in the hour, there are certain things that you need to be in a physical space for. And our job as providers, which we have done poorly at, is to help triage and make sure that the people who are on the front end of figuring out where you get seen, whether it might be people now, might be software in the future, get it so that you wind up in the right place with the right level of service for your needs, and not, oh my gosh, you're on a telehealth visit, but you really should be in the office. Let's try to bill the insurer twice for that. They don't like that.
No, I get it. So we're going to wrap up here in a few minutes, but there's going to be some rapid questions really quickly. Don, value-based care, is it adopting? Is it starting to grow from that perspective? I know this is probably a full episode on its own. And Joe, hospital at home, right, from that perspective. So Don, what's your thoughts on value-based care?
So value-based care is on a slow roll forward, not as rapidly as you can. I will tell you that in the 1990s, when I was deeply involved in capitating primary care, full professional care, global capitation, it was far easier to go to a health plan and get a capitated agreement for whatever you wanted than it is today to get a simple value-based contract on one narrow area. So the health plans talk about it a lot, but their actions on it don't actually match their words. I, at a virtual first conference in Boston in Joe's backyard, I was on a panel and was asked this very question. And the question is, what should you do about fee-for-service medicine? And I had 3 health plans and myself on the panel, and I said, if the health plans won't give you what you're asking for, which is value-based care, which is what theoretically they're asking for and desire, then go ahead and screw them over on fee-for-service. All 3 health plans came up to me afterwards and said, I really wish you hadn't said that. And then they said, but it's true.
Yeah, there you go.
So I think the answer is they want it. They're just the infrastructure that does the contracting, the rules of the game they want to apply on their side are just not all well thought out yet, and they can't adopt it at a rapid scale yet. But we're definitely seeing pockets of it moving along, number one. And number two, the investor community basically won't make an investment in a healthcare service provider or even technology unless it's lined up to support value-based care in the future. So it's a requirement from an investor perspective.
Awesome. Joe, on hospital at home. And
Yeah,
I use that term loosely, right, as well. There's the official hospital at home, but go ahead.
No, it's having a moment right now. I think it might be might not be a long-term success until we work a couple things out. So of course, that might seem odd because I'm such a, again, get stuff out of the hospital into the home, but there are a couple of things that haven't been worked out. One of them is the long-term reimbursement strategy. They're living on Medicare waivers right now that followed the pandemic and are now through, I believe, till the end of 2024 with the omnibus bill that passed in December. So, but there's not a long-term, and if it doesn't get reimbursed the same as being in the hospital itself, you'll see that retreat. And then the second part is it's not really fair to compare because we're using home labor that we're not paying for, let alone home brick and mortar that we're not paying the rent on. So people come into and say it's less expensive to do it that way, but I don't think they've taken full account of the costs. And we have to figure out something for the caregiver part of it because it's just too much of a burden on the home caregiver to not have it more sorted out. So I think those are some hurdles, but if we can get beyond those hurdles, it's got huge potential.
That's what I think is healthcare's contribution to the gig economy, right? Is what you just described, right?
Yeah.
By using the home and caregivers and people going home to do blood draws and biopsies and everything else, right? As well, using their own cars and everything else.
It's
right?
a huge logistics challenge. Huge.
Yeah, I get it. So let's wrap it up by going through and tell me, Dr. Kvedar, what is the one thing you're seeing out there right now, or two things that you're saying that really are impressing you? People are getting it. We're starting to move forward, right?
Well, and I take that to be a short time horizon question. Because we could all talk about what's going to happen in 10 or 15 or 50 years. But two things for me that I'm excited about: home testing, we alluded to that earlier, really coming. And again, the another thing that pandemic did for us was people got used to doing home tests. So now, whether it's home tests for a variety of things, and despite the Theranos setback, that sort of technology will be in place in the not too distant future, where you can do a drop of blood and do a bunch of things. And so I think that's exciting. Home devices like the TytoCare device, I think that's fascinating. I don't know how we get one of those in every medicine cabinet. When I was a kid, we had a mercury thermometer. Mom took our temp if we were sick. I think the TytoCare is the 21st century version of that, but I don't know how we get one in every cabinet. But if you had the home testing and the home device like that, your world for virtual care opens up so much bigger than right now. It's mostly behavioral health.
Awesome. Don, your thoughts?
So I'm excited about two things. One is applied AI, especially in ways that effectively answer a question that I equate with the following. If you imagine a patient going through life and every day acquiring a little bit more information, maybe it's because of a doctor's office visit, maybe it's because they took their blood pressure at home, etc. But they constantly do another thing that's related to their health. And then they ask themselves the question, what do I do next? And nobody's got to come up with a solution to answer that question. What do I do next? I've got a little more information, but do I wait 3 months until I go see my doctor, at which time I'll have forgotten all the stuff I did? Raise the question. And so there are some solutions starting to come out that are based on AI, including some chat and simulation that are going to address this what do you do next issue. And I think that's going to be potentially the beginnings of a bit of a game changer. And so you can imagine, something that is equivalent of your personal assistant, especially if they have access to your full medical record. One of the examples I've seen, for example, says, for example, oh, it's time for your annual mammogram. And by the way, we notice you have dense breasts. So would you like us to also schedule an ultrasound? And would you like me to schedule it for you now?
Mhm.
So I'm going to take out the complexities of scheduling. I'm going to take that out of the equation, but I'm actually looking at it and personalizing it in a way that's a little more personal for the user. So that's one of the exciting areas. The other exciting area is payers are waking up and beginning and in some pretty interesting ways for credible companies that have credible management teams, creating new ways of payment, new bundles of payment, effectively, I wouldn't say necessarily throwing out CPT codes, but reorganizing what's being bought, what the transaction actually looks like. And that's really important, especially if you want to create multidisciplinary solutions. And frankly, a lot of what we need to do is our multiple disciplinary solutions. But you have to re-engineer the payment cycle. And just on that, I can paint the picture. A maternal fetal medicine specialist makes the majority of their money by doing lots of ultrasounds. So we make the woman who's pregnant, ever getting bigger and bigger and bigger, travel a lot to his or her office to get the ultrasounds, when in fact the ultrasounds could possibly be done somewhere else. They just need to interpret them. But they wouldn't work financially for them, because right now they need their E&M management codes and the ultrasounds to make up what they would view as an acceptable compensation for the year. So here we have a system that, because of the way we pay them, we make women who are ill-suited to be doing the travel, because that's the only way the doctor is going to make enough money to stay in business. So that's dumb. Yeah. Especially when you think about the rural marketplace and 50% of women not even being in really reasonable travel distance of a physician with that expertise. So those are the kinds of things that we need to fix, but we have to re-engineer the money.
Don, it sounds like you need to start the tricorder initiative again, right? That's out there. Sounds like the timing's right for it now.
That was a fun project. The $10 million tricorder was definitely a fun project.
You can actually take the title care, put it in with an ultrasound, and they can start with the ultrasound, and then as the kids grow up, they have the title care, right, that goes with it, and then do home testing.
I'm sure Joe has seen it. We're not that far away from you being able to do your own ultrasound for certain things, to capture the machine, verify you captured the right images, transmit the images. These are things that are possible. So whether it's the physician who's never done an ultrasound themselves before and doesn't really know how you capture the image, or whether it's ultimately maybe a consumer who's doing it, I'm not sure where that's going to go, but the technology is going to enable it.
I'm going to let you guys go. This has been a fascinating conversation, and I'm sorry I couldn't get to everybody's questions today. By the way, my appearance on here was done through a persona and chat GPT, right? So Kent wasn't actually here from it, but I want to thank you again for attending today, and thank Dr. Kvedar and Don for participating this afternoon. Your great insights. We'll post this recording on newnormal.buzz. We'll actually send it out in an email probably this evening. You can find details on the upcoming episodes on the newnormal.buzz. So have a great day. And guys, thank you so much for a great session.
Thanks for having us.
Thanks, Joe.
Thanks.
Appreciate doing it with you. Thanks, Ken.
Thanks, guys. All right. Bye-bye.